Today's talk of cardiology module is going to be on myocarditis. I'll straight away move on to the lecture. So the outline of the lecture is going to be like that. First, we'll be discussing about the definition, then the etiology, then we'll talk about the presentation, and we'll move on to the investigations and how to diagnose myocarditis. And then later, we'll move on to the treatment and the overall prognosis of the condition. And lastly, as usual, we'll discuss a couple of MCQs. And with that, we'll wrap up the lecture. So first question is, what is myocarditis? In other words, what does it mean? So myo means myocardium and itis is a suffix for inflammation. So it's simple. It's basically the inflammation of myocardium which causes myocardial dysfunction. So don't worry, no one will ask about myocarditis definition in an exam. But what we need to know is myocarditis is mostly acute. But having said that, there are subacute and chronic variant of myocarditis as well. But for the undergraduate curriculum, for the exam purposes, it's mostly acute. Unless proven otherwise, myocarditis is acute and global. So just for interest's sake, Chagas disease can cause acute and mostly chronic myocarditis as well. That's for an example. And myocarditis is generally global. That means myocarditis, whatever the inflammation of myocardium will occur in all parts of the myocardium. So the whole heart myocardium would be involved. But having said that, there are focal variants of myocarditis as well, which is irrelevant to the undergraduate curriculum. That is for the postgraduate curriculum. So for undergraduate curriculum, myocarditis is mainly acute and global. And in certain instances, myocardium lies next to pericardium. So it's not a surprise. At certain instances, myocarditis can be associated with pericarditis. In that case, we call it myopericarditis. Okay. So with that, we are left to discuss the etiology. So why would someone get myocarditis? So to answer that question, this is an important topic when it is concerned with exams. Okay. So there are MCQ stems on the etiologies of myocarditis in undergraduate and even in postgraduate exams. But unfortunately, if you go on to memorize or by heart the list, it's not going to work because the list is exhaustive. So it's not practical for us to memorize everything. So for the exam purpose, what they expect is you to know the important etiologies. Those are clinically also relevant. So here I have categorized the list under 3 topics: infections, inflammation, and drugs and toxins. So infections, they're the most commonest cause, and out of that, viral infections are the commonest cause of myocarditis. And traditionally, we say Coxsackie B virus, which is an enterovirus, is the commonest cause for viral myocarditis. So it's a famous stem. So viral myocarditis is the commonest etiology, and out of that, an enterovirus like Coxsackie B virus, Coxsackie B, is well known to cause myocarditis. But later on, the researchers has found so many viruses can cause myocarditis. It's not limited to Coxsackie or any other enteroviruses. So HIV, CMV, EBV, and even the COVID virus can cause myocarditis. So it's a huge heap of viruses. But out of that, if we can say an enterovirus like Coxsackie B causes myocarditis, it's more than enough. And certain bacteria can cause. Out of that, important thing in Sri Lanka is leptospirosis. It's well known to cause myocarditis. And atypical infections like mycoplasma or rickettsial infections are very common to cause myocarditis in a Sri Lankan setting, apart from viruses. But in the overseas exams, you might encounter myocarditis due to Lyme disease as well. So diphtheria is one of the other bacteria which is well known to cause myocarditis in the pre-vaccination era. In the good old days, sometimes people do present with sore throat and chest pain, and ultimately they get diphtheria myocarditis. It's very rarely seen nowadays because of the vaccination. So just for the exam purpose, I have included diphtheria as well. And certain other fungal, protozoal, and worm infections can cause myocarditis. Out of them, the important ones are trypanosoma, causing Chagas disease, and worms-wise, Toxoplasma gondii is an important thing. But this is not the limited list. It's an exhaustive list. If you can memorize or by heart these things, it's more than enough. And out of inflammatory causes, SLE, connective tissue disorders, autoimmune disorders like SLE can cause, and certain other uh, small vessel vasculitis can cause it, but it's not important for the undergraduate curriculum. And there's a condition called giant cell myocarditis, where you get macrophage giant cells in the myocardium. So that can also cause myocarditis. We don't need to know in detail about giant cell myocarditis for the undergraduate curriculum. If you can know that it can cause myocarditis, that's more than enough. The lower picture in this slide shows a giant cell myocarditis with a giant cell in the myocardium, and the greenish picture is a demonstration of Coxsackie B virus. Because it's the commonest cause, I've included it here. And moving on to the third category of groups, they are drugs and toxins. So narcotics like cocaine can cause myocarditis, and doxorubicin is a famous chemotherapy agent which can cause myocarditis, but it's also not limited. Certain other chemotherapy drugs like cyclophosphamide and so many other antibiotics can cause myocarditis, so it's not limited. And vaccines, COVID vaccines, smallpox vaccine, tetanus, and so many other vaccines also can cause myocarditis. So the intelligent way would be to memorize the important causes and the classes. That would be more than enough, rather than going and memorizing the exhaustive list. So now we discussed about the causes or etiologies, and now we are left with the presentation. So how do they present? So clinically, there is a chunk of people who can be asymptomatic, but most of the others are symptomatic. So when it is concerned to symptoms, there are symptoms related to myocardial dysfunction, and there might be symptoms related to the underlying disorder. For example, most of these myocarditis are post-viral, so they can have upper respiratory tract symptoms or GI symptoms. For example, the viral myocarditis usually presents with fever, sore throat, nasal block, nasal discharge, and sometimes diarrhea even. Okay. So sore throat won't be a sore throat used to be a predominant symptoms in the diphtheria era, where people got sore throat and then they got myocarditis, but now it's not very commonly seen. And in certain conditions like vasculitis or autoimmune disorders like SLE, they might have the other manifestations of the disease, rashes, arthritis as well, but we don't need to know in detail about them. But the rest of the cardiac symptoms are specific to myocarditis. I mean, compared to the etiology-wise, specific in the sense, none is specific, but there are symptoms which can localize to the myocardium. Say chest pain. The chest pain may be atypical, and sometimes it might be positional, especially when there is an involvement of pericardium. Okay, so when there's involvement of pericardium, it might be a positional chest pain. Otherwise, it's just a chest pain. And patients can present with features of arrhythmias like palpitations, syncopal episodes, and stuff. And patients can also present with heart failure, shortness of breath, orthopnea, paroxysmal dyspnea, and edema even. And rarely people can have sudden cardiac death here. So basically, when you have inflammation of the myocardium, your myocardial function goes down, so you get heart failure. If the conduction system of the myocardium is affected, you get arrhythmias. So that's the basic idea about that. And in the examination, basically what you are going to look for is features of a myocardial dysfunction in the form of arrhythmia. So you might have bradycardias, tachycardias, and you may expect to see features of heart failure. And very rarely you might see the systemic manifestation of an underlying disorder as well. For example, SLE. Typically, a patient presents in a young age with acute onset of respiratory symptoms, chest pain, giddiness, and you suspect myocarditis. How are you going to evaluate? So basically, if you do the full blood count, in viral myocarditis, you might see lymphocytosis, or maybe the count might be normal even. And in eosinophilic myocarditis, like worm infections, hypersensitive myocarditis, you might see significant blood eosinophilia even. And inflammatory markers are not specific. Sometimes they might be elevated, but sometimes even in viral infections, CRPs might be normal. So they are not very helpful. And cardiac biomarkers, mostly they are elevated, CK or troponins, they are elevated. And ECG shows non-specific changes, ST elevations, ST depressions, T flattening, T inversions, and there might be evidence of arrhythmias as well, atrial fibrillations, heart blocks, or anything, or bundle branch blocks, anything can occur. So So this brings us to a problem. Now, it's very difficult in the clinical setting sometimes to differentiate myocarditis from an acute coronary event because the cardiac symptoms are non-specific. So no symptom is specific for myocarditis. Okay, chest pain, shortness of breath, heart failure, palpitations, arrhythmias, if anything can occur in an acute coronary event as well. So how do you suspect myocarditis? So if a patient, a young patient with no vascular risk factors comes with chest pain, elevated troponin, ECG changes, and if he has some features of a viral infection like fever, sore throat, nasal congestion, then you might think myocarditis. But if you don't have a predominant fever, and if the patient has vascular risk factors, and then you'll have to evaluate further to exclude an acute coronary event. So you might even have to do an angiogram. Okay, so clinical diagnosis of myocarditis is not very straightforward as we assume. Okay. And if you do the chest X-ray, in the later stages, you might see cardiomegaly, features of heart failure, but in the early stages of myocarditis, X-ray may be normal even. And 2D echo is an important investigation, but it is not diagnostic. 2D echo will help us to diagnose. So in acute coronary syndrome, usually the regional mole hypokinesia or the regional wall motion defect which you see is territorial. If the acute coronary syndrome involves the inferior territory, you might see inferior wall hypokinesia, and if it is anterior, you might see anterior territory hypokinesia. But whereas in myocarditis, the myocardial involvement is global, so you get hypokinesias in all the myocardium. So that would help us for a certain extent to confidently diagnose myocarditis. But having said that, I told you there are focal myocarditis as well, but this is too much for undergraduate. So for undergraduate level, we say echo is a reasonable investigation to differentiate myocarditis from acute coronary syndrome because myocarditis will cause global hypokinesia. And you can do cardiac MRIs again to show the late gadolinium enhancement, hypokinesias of myocardium, and etc. Cardiac MRI will not be questioned for undergraduates, so I won't talk about that further. And endomyocardial biopsy. So the best way to diagnose myocarditis would be to go for a biopsy, but it's invasive. So most of the cases won't require an endomyocardial biopsy to diagnose. So there are various criteria to diagnose myocarditis, depending on the clinical features, cardiac biomarkers, and imaging with echo or MRI. So most of the times we don't need a biopsy. So, but if you want a best investigation to diagnose myocarditis, that would be myocardial biopsy for the exam purpose. So that is the best test to diagnose. But it's not necessary in all cases. So if you do a biopsy in a viral myocarditis, you might see lymphocytes infiltrating the myocardium. So in this picture above, you see so many lymphocytes infiltrating the myocardium. This is a normal part of myocardium. This is the inflamed part. And this is the global dilatation of the heart in myocarditis. And sometimes it might be associated with pericarditis, so you might see pericardial effusions as well. So we know, so when you suspect myocarditis, you might be doing the basic blood workup, cardiac enzymes, ECGs, and echo. And if the clinical tempo of the presentation is not fitting with the typical myocarditis, you might evaluate further with an endomyocardial biopsy or angiograms. But in most cases, it's not necessary. So even basic investigations, cardiac biomarkers, and an echocardiogram would be more than enough to diagnose myocarditis. Okay, so then once we come to a diagnosis of myocarditis, now how are we going to treat them? Okay, so treatment, there is no specific drug for myocarditis that we should understand. There's no specific treatment. So treatment depends mainly on the treatment of the underlying disorder. For example, viral myocarditis, most of the virals is Coxsackie and stuff, they don't need treatment. So they resolve on their own. You just need to support the patient. But there are certain viruses like HIV where you need to treat HIV with antiretrovirals. Okay. And there are bacterial infections. We saw that they can cause myocarditis. Leptospirosis. You treat leptospirosis, Lyme. You treat Lyme. Diphtheria. You treat diphtheria. So those are the treatments of underlying conditions. For example, SLE or giant cell myocarditis. You treat with immunosuppressive drugs. Okay. And the other main arm of treatment is supportive treatment of the complication. So I told you myocarditis can present with heart failure arrhythmia. So if an arrhythmia occurs, you treat the arrhythmia. You may refer to our arrhythmia lectures to see how arrhythmias are treated. And we discussed about heart failure management. The same thing is done here if the patient has myocarditis and heart failure. So we discussed the heart failure treatments extensively in the last lecture. So go through that lecture as well to see how heart failure is treated. It's exactly the same way, even in viral myocarditis with heart failure. So I just put these things, the controversial topics, for the exam question purpose. Okay. So NSAIDs have no place in myocarditis. So NSAIDs may be tried in pericarditis, but not in myocarditis. So there's no place for aspirin or diclofenac or ibuprofen or brufen, anything. No place for NSAIDs at all. Sometimes certain studies have shown they are detrimental even. Steroids is very controversial topic. For viral myocarditis, no, steroids have no place. Though they can improve the ejection fraction a bit, but there's no place for steroids in uncomplicated viral myocarditis. But if there's significant heart failure, you may try because steroids might improve the ejection fraction. But otherwise, uncomplicated myocarditis, no place for steroids. But having said that, steroids have a place in certain types of myocarditis. Say it's SLE myocarditis or hypersensitive myocarditis. Yes, of course, steroids have a place. And the other immunosuppressives have a place in eosinophilic myocarditis, giant cell myocarditis. You might treat with immunosuppressives. So those are the specific agents. And now IVIG, immunoglobulin, is coming up. Even they are trying it in viral myocarditis, but it's too much for you guys. Okay. And how about the outcome? So a patient might ask, now I have had a myocarditis. Will I get it again? Will I resolve? Will I have heart failure forever? It's very difficult to answer. Most of these acute myocarditis are due to viral. So most of them resolve completely. So the outcome is very good in usual cases. But having said that, some of these post-viral myocarditis can result in dilated cardiomyopathy. So their symptoms might persist and they might have this cardiomyopathy forever. So it is very important for the exam point of view. Post-viral or viral dilated cardiomyopathy is a common sequence. It's a well-known sequence of myocarditis. It's a famous stem. So for exam purpose, yes, viral myocarditis can result in dilated cardiomyopathy. If you know that, that's more than enough. So with that, we'll conclude the lecture and we'll move on to the question and answer sessions. So there are two sample questions from the past exams. So I'll move on to the question straight away. MCQ. Which of the following is true regarding myocarditis? Viral infections are recognized as common cause. True or false? Yes, it's true. There is a huge heap of causes for myocarditis. So when it comes to acute myocarditis, viral infections, especially the enterovirus like Coxsackie B, is well known as the commonest cause of myocarditis. So yes, but apart from Coxsackie B viruses, there are certain other enteroviruses, and there are other viruses like CMV, EBV, and even HIV. COVID can cause myocarditis, and not only viruses, bacteria, fungi, worms, and inflammatory conditions, and even drugs and toxins also can cause myocarditis. But viral infections are the commonest cause of myocarditis recognized so far. So STEM A is true. May present with heart failure symptoms. As I told you, when the myocardium is involved, myocardium is the main pump of heart. I mean, heart is a pump, but myocardium is the basic structure of that pump. So if the myocardium is not functioning because of inflammation, there's no way that heart can function. So people can have heart failure. So they can present with features of heart failure. So heart failure is a well-known complication of myocarditis, so it might be the presentation even. But it's not only the heart failure. Myocarditis can cause inflammation of the conduction system. So they can have arrhythmias, bradyotachyarrhythmias. So what they say is, when it comes to arrhythmias, usually the initial part of myocarditis, they go into bradyarrhythmias and then later they proceed into tachyarrhythmias. So tachyarrhythmias are very common late sequelae of myocarditis. Okay. But apart from that, they can have chest pain, they can have pericardial involvement with pericardial effusions or pericarditis, and they can also even have sudden cardiac death. And the rest of the symptoms of myocarditis can be due to underlying the cause. Like if it is viral fever, viral infection, you can have fever, upper respiratory symptoms as well. Okay, STEM C. So STEM B is true, A is true. Endomyocardial biopsy is needed to diagnose in all cases. No, that's clearly false. We don't do biopsy in most of the cases because in most of the cases from the history, examination, cardiac biomarkers, and ECG and echo, we can make a confident diagnosis of myocarditis. And there are clinical criteria to diagnose myocarditis, which is not needed for even postgraduates. Okay, so we won't be talking about the criteria, but those are more than enough. So, but there are certain cases where the patients might not have fever, they might have vascular risk factors, things might be equivocal. So in that case, you might be forced to do a myocardial biopsy. So myocardial biopsy remains the best investigation to diagnose myocarditis, but it is not needed in all cases. So stem C is false. Troponins may be positive. Yes, most of the cases, troponins are positive because with inflammation, you get myocardial damage. So it's basically myocarditis pathogenesis is an inflammation of the myocardium due to various causes. If it is viral myocarditis, you get lymphocytic inflammation, and then myocardial inactivity is lost. So myocardium might undergo necrosis and inflammation, and the myocardial constituents like troponin and CK can come out to the circulation. So as a result, troponin, CK, anything can go up in myocarditis. ECG may show HT elevations. Yeah, it's one of myocarditis is one of the well-known causes of ST elevations. But apart from ST elevations, they can have ST depressions, T inversions, and even features of arrhythmias. Okay, last question. True or false regarding acute myocarditis? Presence with fever and chest pain. Of course. So fever is a predominant symptom. So if a patient have fever, that's easy for us because it reasonably differentiates from a myocardial infarction, because most of the myocardial infarction due to acute coronary syndrome won't have fever. So most of them won't have fever, 99%. So if a patient comes with chest pain, fever, ECG changes, and troponin elevation, it would be helpful to diagnose acute myocarditis. So presence with fever and chest pain is true. 2D echo will confirm the diagnosis. No, the confirmation is done by myocardial biopsy and the criteria. So 2D echo will be very helpful to come to a diagnosis, especially if it shows global hypokinesia, but it will not confirm the diagnosis. That is false. Prednisolone is indicated in all cases of myocarditis. No, most of the viral myocarditis, they resolve on their own. But if the EF is very low, you might consider prednisolone. And there are certain conditions where we might use prednisolone, like SLE myocarditis and certain worm infestations along with antihelminths, you might use prednisolone. But in all cases, prednisolone indicated, that's false. But the important thing is NSAIDs, aspirins or ibuprofens, they are not indicated at any cases. So NSAIDs are complete false, prednisolone depending on the case. But in all cases, that's false. Trichinella causes eosinophilic myocarditis. As I told you, the commonest etiology would be viral infections, especially enterovirus like Coxsackie B, but certain bacteria, fungi, and protozoans can cause. Trichinella spiralis causes eosinophilic myocarditis. That's true. If you do the myocardial biopsy, you might see the encysted vermin as well in the biopsy. Viral myocarditis may result in dilated cardiomyopathy. Yes, it's a famous term. Viral myocarditis usually resolves on its own, but rarely it can cause dilated cardiomyopathy even. So this brings us to the end of the lecture. Thank you. And if you have any questions, I'll be happy to answer.